Hello students, good evening and namaste. Welcome back. So this will be the last lecture series on the mechanical ventilation and we'll be discussing about the weaning of the ventilator. So we have discussed almost majority of our things in all the basics of the basic physiology of the respiration. We have discussed about all the pressures, the pressure flow volume curves, as well as we discussed about the lung compliance. We also discussed about the conditions like ARDS and COPD, and in the last we also discussed about the conditions in COPD in the acidosis. We have discussed about the various vent settings, what are the normal settings which we do, and in the last, and we also discussed something about the non-invasive ventilation, which is both the bypass as well as we just touched upon the CPAP. And in the last, now once we know everything about the almost all the basics about the ventilators, now we should also know that okay, now when do you actually take off the patient? So weaning is actually the older term. The newer term is the liberation from the ventilator. So how and when do we liberate the patient from the ventilator? So weaning of the ventilator of the patient. So weaning or liberation of the ventilator. So as you all know, you cannot keep a patient for a very long time for a ventilator for all the obvious reasons. The one thing is that whenever you keep a patient on a ventilator for a longer time, there's always a risk of getting a infections, and the ventilator associated infections are very difficult. The most common organisms is basically the pseudomonas, and pseudomonas infections in the lungs are very bad. It's very bad, and especially if a patient is already suffering from other respiratory illness, then in those conditions these things becomes very difficult. And since all these patients are basically bedridden, because whenever the patient are on a ventilator, they are kind of sedated. Of course, we do not sedate them to the level that they cannot have their own breaths, so means their respiratory centers are working, but since all of them are sedated, they are not moving, and that is the reason these patients actually have a very poor immune systems, pure immune response. So they are kind of immunocompromised as well. Again, you have to think that when you keep patient for a very long time on a ventilator, their immune health is actually very poor. And next thing is, since you are giving support continuously, so if you are giving support for a very long time, so these inspiratory muscles, the diaphragm, the intercostal muscles, whose actual function is to take inspiration, they actually gets weak because they are not actually pumping. Now they are not generating that much force because they don't have to generate the force. You are giving the force from outside. So when you use it for a pretty long time, they starts getting weak. So that is the reason, again, if you put these patients on a very long time, so it becomes difficult for them to actually take them out from the ventilator. So that is the reason it is always said that whenever at the earliest sign when you see that the patients are actually improving, you have to actually start using the weaning protocols, because you don't want the patient to be on a ventilator for a very long time. The first thing is that whenever you try to wean the patient off the ventilator, is that you, of course, you need to reduce the sedation, and then you try to wean the patient off the ventilator. So the first thing is, before we go how do we wean, so we should know that when you should not wean the patient. So when you know the patient is grossly unstable, so you know that the condition, the patient who has come in is actually highly unstable. So of course you will not try to wean the patient off, because even when you try it, the patient is eventually will fail to wean off, and you need to actually give him or her the ventilatory support. If the patient is only stable at more than 45% of fractional oxygen, so when you are monitoring the oxygen saturations, and when it's coming to around over 90%, 90 to 93%, only when the FiO2 is at more than 45%, then that's not a good thing. That means the patient is basically not stable. He or she is not able. So when you wean this patient off, so when you wean off these patients, he or she will be actually having 20% of oxygen, which is the 20% of oxygen. So these patients will actually deteriorate very fast. And if a patient is on a vasopressors agent, so in the patient who are on shock and who are on vasopressors, not just when the IV fluids alone cannot control the blood pressure, and you need to give them dopamines or other vasopressors, and then of course you should not try to wean these patients. So then we have something known as the weaning protocol, which is done in these kind of patients. So the first thing what we do is something known as a spontaneous breathing trial of the patient. So I'll just explain you what this is. So the first thing is we do something known as a spontaneous breathing trial. So basically in a ventilator you all have seen that the patient are basically getting some kind of a support in sense of a pressure on a volume. So what do? You remove all the supports. So that does not mean you actually extubate the patient, you remove all the support from the machine, or you just keep the support which is to the level of physiological level. On, let me say, not just this, or you just keep at physiological levels. So basically, let's say a patient is having some pressure support, that he'll getting that when he initiate a breath he'll be getting a this much amount of positive pressure which will come in to give the volumes. So basically you or let's say let's take a simple example. Let's say you have a patient of COPD and you want to wean that patient off. So we read that there is something known as we increase the inspiratory flow rate, right? So you know the normal inspiratory flow rate is 60 liter per minute. So what you do, instead of giving 150 liter per minute, you just keep this IFR to 60 and then you try to see. So basically at the physiological levels, the amount of pressures, volumes you want, you keep that and then you see how the patient is doing. If the patient for few hours is basically stable, then that's considered to be a positive spontaneous breathing trial. Means that patient can breathe normally even when you take the patient off from the ventilator. So this is very, very important. So that is the first thing you do. Now the second thing we do is something that is known as a Tobin index. So we to calculate a Tobin index. So in this what we do, in a Tobin index, this is basically respiratory rate divided by tidal volume, and this is, please remember, this is in liters, not in ml, because we are so used to tidal volumes in ml. So what does this mean? That if respiratory rate is high, let's consider, let it to be 30, and let's consider tidal volume to be 300 ml. So you can consider it to be zero point 0.3 liters, right? So let's say this is what you got. So what do we get here is 300 divided by 3. So that means the Tobin index comes out to be 100. Or let's say the patient is actually breathing slightly higher, or let's say the patient is breathing even having a even shallower breath. So this might actually go to, let's say, if it becomes 0.2 liters, then that will come out to be 150, right? So what does this mean? The Tobin index basically means, so when a patient comes out of ventilator, you want him to breathe normally, just like you do and I do, right? So that does not mean you do not want him or her to take a very fast and a rapid breath, like you do not want like that. You want that the patient when he gets out is very, very comfortable. So what do you want? You want this respiratory rate to be low and you want this tidal volume to be high. Tidal volume high means you should be reasonable, like something around 400 to 500 or 600 ml. That's a reasonable. So that's what exactly the physiology do. So that is a reason it is said, if this Tobin index, if Tobin index is more than 105, then it's a bad sign. So basically it will be high when, so basically Tobin index was directly proportional to respiratory rate and it was inversely proportional to tidal volume, right? So this will be high when respiratory rate is high, so that is the patient is breathing rapidly and the tidal volume is low, so he or she is having a shallow breathing, which is not a good sign. So basically Tobin index means that the patient should be breathing normally. Apart from that, what do you look in a patient of when you want to wean the patient off. Apart from just this, since all these patients are on a in an ICU setting, so you are always checking the ABG level. So of course the one thing which you will always keep in mind, that the ABG should be almost like a kind of a normal. So if a patient is having a 7, if you want to wean the patient off the ventilator and the patient's PHU comes out to be 7, so of course you'll never try for that, because then you cannot control the PCO2 levels, or it may go up, or a patient has having certain other issues. So then you need to ensure that the ABG is reasonable. I'm not telling it should be perfect, but it should be reasonable, right? Because in let's say when we talk about COPD, we might actually have a we might keep this as something around 7.28. We can actually have that, and we can actually take the patient off. So basically, we need that the ABG should be reasonable. Okay. One more thing, when we do not do is we also need to look at the PCO2 levels. So if the PCO2 levels are basically more than 45, if they are more than 45, then basically we do not try to wean the patient off, because then that means the patient is basically in a respiratory failure. So we do not actually try for a respiratory failure patient. We are not very happy to wean these patients, because then they actually can go into more difficulty. So even on a ventilator, if they are having PCO2 more than 45, then you can imagine when you take these patients off the ventilator, then their PCO2 will actually go up, especially in a setting when they are having a problem when they are having an acute condition, and they are having this kind of issue. So then you need to be very sure. Second thing we always look at is a PO2. Now one more thing, there is one more thing we take into account is a minute ventilation. So in an acidosis, we talked of the minute ventilation. So in a minute ventilation, when we talk, so if a minute ventilation is more than 10 liters per minute, so whenever the minute ventilation is more than 10 liters per minute, then basically that means the patient is not stable. The patient's metabolic requirements are very high. So this means patient metabolic requirements are high. That's why he requires more ventilations. That could be because of any reasons. It could be that the body might be compensating, or for any other reasons. His or her metabolic requirements are high. So when you wean these patients off, they'll be actually doing a very rapid and a shallow breathing. So that's again not a very good sign. And one more thing, if a patient normal respiratory rate, is more than 25, then again that's a sign that you should think, okay, this patient will actually is not a very good candidate for weaning. So then if a patient's normal, or like doing a spontaneous breathing trial, you find that the patient's respiratory rate is more than 25, then that actually is not a good sign. It's not a good sign. So that you need to keep in mind. And then there are other parameters. So one last parameter which we always try to see is a NIF. So basically it's a negative inspiratory flow. So what happens is, just like whenever we try to take in a breath, so we mentioned that it's a negative pressure ventilation. Okay. So whenever there's a negative pressure ventilation, so when this pressure, so when a body's you want in a physiological level, you need that it should come to somewhat about into the negative. So let's say if it's around 27 H2 or 27 of water, then it's good. But when you are not getting this kind of a picture, when the body is unable to generate this amount of force, then that patient will actually worsen after you take these patients off the ventilation, or you need to you need to put these patients again back on ventilator. So that is those things are supposed to keep in mind. So basically we talked about the spontaneous breathing trial, we talked about the rapid shallow breathing index or the Tobin index, and we also talked about the ABGs, and we also talked about the NIF and the minute ventilation. There's one more thing that we also calculate is a PaO2 upon FiO2 ratio. And again, that's the same thing. If the PaO2 is bad, so again, that you mean that the PaO2 is not good. So the oxygen in the blood is not good. So of course, you don't want those patients to be out of ventilator. And again, FiO2, as we mentioned in the previous slide, that if a patient is stable on FiO2 more than 45, then you cannot actually wean those patients off the ventilator. So these are the things. The major thing is spontaneous breathing trial, and of course the Tobin index or the rapid shallow breathing. And again, the ABG and the minute ventilations are important, which you need to look at it. And at various places, the people follow different kind of protocols for when to wean. So apart from that, the best thing is that the first thing is you need to have the patient's mechanics of ventilation is good. So that's a spontaneous breathing trial should be good, or the spontaneous breathing trial should be positive, and of course the ABG should be good. So as we mentioned that when you keep these patients into the when you remove keep the pressure support to the minimal or to the physiological level for few hours. So after few hours, when you check the ABGs and the ABGs comes out to be good and comes out to be very satisfactory, then that's a positive spontaneous breathing trial. So that means the mechanics of ventilations is good. Then you need to ensure the mental status of the patient. That is very important. Let's say the patient is of stroke, and these patients who are of stroke, then even when you take these patients off the ventilator, then their respiratory centers might actually not work properly. So then you need to ensure that these patients are on the ventilator. And similarly, the patients of head trauma. So the on a many conditions, or a patients who have got a intracranial hemorrhage and you have done a burr hole. So many times these patients are on ventilator for months till the time their mental status improves. So their lungs are perfect, they don't have any issues, but the problem is in the higher centers. So till the time those higher centers are working properly, you cannot actually take these patients off the ventilator. The third thing is we also put the ventilator not just for ventilating the patient, but many times we also put the ventilator to ensure the secretions are not coming in. So if you see that while you suction the patient, so when we talked about the compliance, so the compliance and during the compliance talk, we talked that we get a increase in the peak pressures that may be due to some secretions, the copious secretions over the ET tube. So very regularly, every time there are a lot of copious secretions coming into the suction tube of these patients of a ventilator of an ET tube, then actually these patients are having too much of secretions. If you take these patients off the ventilator very soon, what happens is these secretions will actually go down into the lungs, and that patient may actually get a aspirational pneumonia or other things. So these things are very risky. So if a patients are actually having too much of copious secretions, then also you cannot remove this ET tube. And last thing we check is for a air leak. So I'll explain you what exactly a air leak is. So basically, this is a trachea, and this is your ET tube. So you all know in a ET tube we have this balloon at the end. Okay. So what happens when you keep this ET tube for a long time? What happens is this ET tube is actually rubbing on the membrane of this trachea. So what happens? There is some sort of inflammation which occurs over here. Okay, some sort of inflammation which occurs over here. So what does this air leak means? In an air leak, what we do? We deflate. First, we deflate it. We deflate this. We deflate the balloon, and we put a higher pressure into the. We put a higher pressure. So what happens when you deflate? And if this inflammation will be low, so when you once you deflate it, and if once you deflate it, and if this inflammation is low, then what will happen? This air, this will pass through this place, and when this air will pass, this will produce a sound, and this is known as a air leak. Okay, so this is actually a good sign. Now I tell you what happens when it's actually not good. What's exactly a positive air leak or a negative? So let's say this is again a trachea, and you have this here. Sorry. So now let's consider when you, even when you deflated, this is kind of deflated, but you had a lot of inflammation over here which has occurred. So much of inflammation has occurred that even when you put pressure, this cannot go out. This air cannot come. You do not listen. You do not hear any sound. So that's a sign that this inflammation, this inflammation is a lot. This inflammation is too much. And whenever there's too much inflammation on this side, what happens? So if in this condition, if you extubate, in this condition, what do you get? There are chances that this inflammation may actually block the airway. This inflammation may actually block the airway. So this is a very risky thing. So basically, what does an air leak means in brief? That when you deflate the balloon, and after deflating the balloon, when you put pressure, you listen or you get a hiss sound over the trachea, that when the air passes in a very narrow space between this deflated balloon and this small amount of inflammation. But if you do not listen that hiss, then that means that inflammation is too much. And then if you extubate those patients, there is a very high risk that this inflammation actually blocks the complete airway. So that's actually not a good sign on a ventilator. So you should always have a positive air leak over these things. So we should always have a positive spontaneous breathing trial and ABG, mental status and secretion. And we have discussed about the air leak. So you should have this checklist that whenever you want to wean the patient, you should always go for this mechanics of ventilation should be good. So we mentioned of not just the spontaneous, we also mentioned about the Tobin's index and the other factors, the mental status, secretions, and of course I told you about what exactly is a air leak. So that's it, and thank you and hope you liked it.